Hello, everyone. Good day. I am Priscilla, and in today's session, we will be discussing quality improvement in healthcare. And our content for today is what is quality in health and social care or nursing care, quality improvement definition in clinical practice or health and social care, the NHS England change module, and we'll talk a bit more about the Institute for Healthcare Improvement module. Um, and then, the three fundamental questions in the PDSA cycle of the Institute of the Healthcare Improvement module. And we will dive a little bit more about measuring improvement in quality improvement project. So, what is quality in health and social care or nursing care? Cambridge, defines quality as how good or bad, something is. And quality in health and social care has different dimensions to it. Unfortunately, there's no distinct definition for quality in health and social care. And so among these, aspects of the quality in health and social care are safety. So when we talk about safety, we mean quality should avoid harm. Anything to do with quality has got to avoid harm, and the whole intent is to help people. Quality has got to be timely, meaning that there should not be any incidents of unnecessary delay. If something is not working and it has been picked on as not being effective or not doing what it's supposed to do, or it's not improving, health and social care, it has got to be worked on as soon as possible, obviously in a safely manner. When we talk about effective providing service based on evidence that has got benefits, we believe in using evidence based practice. Sometimes certain changes might not necessarily be based on evidence. However, it is recommended when we talk about quality, effective, it has got to be based on evidence that translate into benefiting the patient or the service user. Efficiency, talk about avoiding waste, whatever quality thing you're panning out should avoid waste. And person centered, we talked about public engagement. It has got to involve people. You have got to collaborate with service users, stakeholders, to be able to, you know, bring out the best. Because remember, we all do not have all the information in our head, and people have got different experiences, skills, and perception that could help translate or transform our health and social care in the best way possible. And equitable we mean by providing care that do not vary in quality. And so whatever care of dementia you're giving to patients in Berkshire, or let me say, in Berkshire in the UK, should not be different from the quality of care you give to the patient in Surrey. It might not necessarily be the same, but it's got to be similar. It might not be the same because of maybe geographical characteristics that probably has gone through some few quality improvement project to make twitches to it to kind of benefit the people in that geographical environment, or based on that characteristics they share. But the underlying key is it has got to be similar, and it has doesn't have to be different when we come to quality and health and social care. And so to define quality improvement in health and social care or in clinical practice, we have to obviously talk a bit more about that. And so, quality improvement basically means involving, using a systematic change method. So, it's a process just to bear in mind. You just don't do it once and that's it. It's a process and strategy to improve patient experience and outcome. The whole intent is to improve the quality of care or the patient's experience and outcome. Um, And remember, quality improvement project brings out measurable improvement to a specific aspect of healthcare delivery with evidence or theory of what might work. So, like I said, we always advocate for evidence-based practice, but sometimes there isn't any evidence to it, and maybe that QI project could probably lead to a research. We can, lead to knowledge that can actually transform, the whole service. But if there is no evidence to support the claim, then obviously it has got to be tested out. And so, yeah. So, delivering quality improvement project requires good leadership skills, and by that we mean that you know there has got to be some form of resilience, and as a leader, you've got to be confident, good communication skills, being observant. And ability to connect with people. Remember, you're working with service users, stakeholders, and the public, and so I've got to be able to connect with people and continuous learning. Like I said, this is a process, it's a systematic process. And so sometimes you might have to learn and learn certain things, and sometimes you might have to, learn new things to make it work, working with people. You have got to be patient. So patience is a virtue when it comes to, undertaking quality improvement. It takes time, and so one has got to be patient, being responsible and accountable as a leader, and whoever you delegate, roles to, got to be responsible and accountable to what tasks they are assigned to, the skill to undertake the project itself. So we need whoever the team, sometimes you might need to use lay people when engaging with the public, but as a leader, you yourself has got to have the skill to undertake and, support the team. Need knowledge on what to do. As a leader, you have got to know what to do. But even working with the people, even if they are lay people, you've got to sometimes how you have to train. You might have to train them, or you might have to support them in ways that they can't, to be able to get the whole cycle going. Intrinsic motivation, as an individual leader or even as a group, people have got to be motivated. Like I said, it takes time, patience, commitment, and so you've got to be motivated. Ability to receive support and give. So what I mean is that you've got to be able to receive support and give support when need be, because when you involve stakeholders or specialists, sometimes you might not necessarily know certain things about certain things, and so you have got to be flexible and give room for people to share the experience and the knowledge on certain things. And working as a team, you can put them together, and so you have got to be flexible when it comes to that. Believe that you can make a difference or an impact. So you've got to believe, like I said, sometimes it takes time, and you have got to believe that you can make a difference. There are varied strategies to quality improvement in healthcare. So we have the lean principle for improvement, and with the lean principle, it involves identifying value, mapping out, creating a flow, establishing a pull system, and striving for, continuous improvement. And we've got the Six Sigma improvement module, which is the DMIC. So the DMIC, D means, you have got to define what the problem is, and define the change as well. You have got to measure, analyze, improve, and continue process to be able to get to the targeted change you plan on achieving with the team. But with this session, we will be talking a bit more about the Institute for Healthcare Improvement module, which is what I've got an experience in, and so that's what we'll be talking about. And bear in mind when these are varied strategies, and so when you choose one, you stick to one to avoid confusion. So the change before we go into the Institute for the Healthcare Improvement module. We just want to talk a bit more about the change module by the NHS England. So this is basically a framework to support health and social care teams to adopt a shared approach to change. So the whole idea is a shared purpose. You have got to use the people, the team. You've got to speak to your manager. You've got to involve the service users. You've got to involve stakeholders. Okay, and so it has got this seven, things to think about. So first of all, spread and adoption, delegate, adopt and adopt and all of that. Improvement tools, use, the tools at your disposal. Project and performance management, you will be working with people, and this is a project, and so you've got to have that skill to be able to work with people and manage, and all of that. Measurement, the system of measurement, you've got to involve that system drivers in your institution, whatever system or force drivers you've got to make use of it, and that sometimes, most of the times, involves people, system protocols, and all of that. Motivate and mobilize. So you're working with people. Sometimes when it's two things are not working the way it's supposed to work out, and it's taking too long, people easily kind of give up. So as a leader and even as a team, got to motivate each other and mobilize whatever resources you've got to kind of keep going. Leadership by all. So, in as much as there is a lead, when you delegate tasks, people should be able to be accountable for what they do. People should, there's got to be that evidence of good communication skill among the team. The plan should be laid out. The aim and everything should be laid out. People should know what to do, who to call, or who to go to when they're not sure about something, when they need an information, and all of that. And it helps to make the whole work more interesting and easy to go by. So we will be talking a bit more about the Institute of Healthcare Improvement module for improvement. So these are you know four things. But the first three involves the fundamental questions to ask, and then we've got the PDSA cycle, which we'll talk a bit more about that. So the first fundamental question is, what are we trying to accomplish? What's the aim? So panning out the SMART aim statement is very, very important. But before you do that, you need to understand the problem and the area that needs improvement. So as a team, obviously, when you're deliberating or discussing, as a team, this is what the whole the importance of the team, comes across. So we all have got a shared, aim statement, and based on the input from others and everything, we can basically map out or understand the problem well, so we can be able to map out our aim statement. And what I mean by the SMART aim statement is, it has got to be specific, it has got to be measurable, it has got to be accurate, it has got to be realistic and time bound. So if you're doing a project, you need to, you know, in the aim statement, you need to identify the period. Is it for 6 months, 10 months? It needs to be in the aim statement. It has got to be specific, should not be vague. People need to know what specifically we're talking about over here. It's got to be measurable, something that, feasible and all of that. It's got to be realistic. Is it something that we can do in 6 months? We're talking about time bound. Is it really realistic? Should we extend the time to 1 year, 6 years? You never know. But most of the time, you don't find quality improvement projects, lasting for that long. Maybe 6 months, maybe a year, but it all depends on the project the team is undertaking. Yeah. So the second question is, how will you know that a change is an improvement? So remember, not all change is improvement. And this question involves identifying an appropriate measure to test out the proposed idea for improvement. So we'll talk a bit more about the measuring the quality improvement project, but it has got to do with observing, analyzing, and measuring outcome, processing, and balancing out. Is very important to measure. So that is what this question, does. How will we know that a change is an improvement? Okay, we need to know that whatever change we think we have, you know, undertaken, or we plan on undertaking, you know, is what we really believe it to be, a change that causes an improvement. And so we'll talk a bit more about that. And the third question is, what change can we make that will result in improvement? So this has got to be the changes. So this is mapping out all the ideas by the stakeholders, by the service users, by the team. Okay, it involves evidence. It involves an idea, an abstract idea by anyone, hypothesis, creative thinking, and exploration. So these are the changes you plan on seeing. So then we go to the PDSA cycle. So the PDSA cycle focuses on testing out the proposed changes. So first of all, you have identified the change. So you identify the aim statement, and then you identify what really is a change, which is the measure. And then so you identify the measure, and then you identify the change. And the PDSA cycle is what you're going to use to test out those changes. And then you measure those changes. And then based on the outcome or the process or balancing out, or whichever way you measure, you can then decide based on, the observations, based on the evidences, you can now decide, well, this is what we have chosen. And so that's the whole idea of the PDSA cycle. So P basically means plan, D is do, S is study, and then act. So you plan, you do, you do whatever you've planned, you study, and then you act. So remember, it's a cycle. So the first cycle, so let me give an example. So for example, I'm in the critical care, so I'm going to use an example from critical care. So we first of all we identify the aim statement, and the aim statement for an example for this session is to improve 4 hourly repositioning of level 3 patients in ABC ICU unit at XYZ hospital by 70% in 4 months period, which is March to June. So maybe we did an audit and we realized that people are not really repositioning patients, level 3 patients, every 4 hourly per the policy or the protocol. And so the audit was done, and we realized that only 20%, you know, of patients were rolled 4 hourly. Hope not, but this is an example. So only 20% of patients were rolled 4 hourly in that particular unit, which was very concerning. And for that matter, there were quite a lot of pressure ulcers. But with this QI project, we just want to improve, repositioning on that ward in that unit. We want to increase that rate of repositioning to 70%, okay, in 4 months period. So that's our aim statement. So how will we know that a change is an improvement? So we will know that the change is an improvement when we have identified a trend or an increase, which is a 70% of whatever changes we plan to undertake, which has resulted in patients being repositioned 4 hourly. So our measure is we mapping out or chatting or observing or documenting the percentage of people being rolled, maybe in in 24, sorry, be enrolled in that, 4 month period, which is March to June. So from March to June, our measure is 70% in 4 months period. That's what we aim to achieve. Okay. So now let's go to the next bit. And now we go to what change can we make that will result in improvement or changes. Sorry, to result in improvements, which is the changes. So we can think about one, educating the staff. We can start with doing bedside teachings of staff on that ward. And then we can think about um, maybe not just the nurses, but the nurses, the healthcare assistants, and all of that. Um, so this is a 4 months period. So we can't think about. I mean, employing more healthcare assistant will be feasible, but think about it: 4 months employing. We might not necessarily employ, but maybe we might think of employing. We can think about that, but we can also think about maybe, you know, opening up for staff from other ward or agency nurses to you know, to come in to work with us. So we'll increase the healthcare assistance on that ward, on that critical care ward. Could be one change. So the first is bedside teaching, increasing the healthcare assistant roles on that unit to support the nurses to roll, because probably at the time when we're discussing, people did come up with the fact that the nurses, were shortage of staff, and nurses did not really have that capacity to, or the health professionals on the unit did not have the capacity to roll the patients and all of that. We can think about also um, maybe the ward manager reminding people of repositioning patients every 4 hourly and all of that. And maybe on what rounds the doctors, adding it to their note and all of that. Let's think about these four for now. So that is what the changes were. Now let's go to the PDSA cycle. So the PDSA cycle, first of all, plan, do, study, and act. So first we take the first concept or idea or maybe evidence, which possibly may be bedside teaching. And with the bedside teaching, so that's the plan. We plan on, how we're going to do it. So maybe every week we undertake maybe 3 sessions among the nurses, among the doctors, among the the healthcare assistants. Yeah, and then the do, we do it. So we undertaking what we have planned out, which is bedside teaching of the nurses, the doctors, the healthcare professionals, every week, like we planned. And then the study. So just to say that before we do any of these interventions, we always have got to have a baseline evidence. So we have a baseline evidence where an audit was done and we know that 20% of the patients were enrolled last year. So that's our baseline. So we'll keep it there. Okay. But then with this particular bit, because we're planning to use the bedside teaching to kind of influence that change, we would, before starting the bedside teaching, we can decide to maybe undertake a mini. We don't have to because we already know the baseline, but we can decide to do maybe a week assessment, something, but we don't have to. So let's say we just use what we have, which is the baseline evidence that we have. The only 20% were enrolled last year, which we already know. And so the plan, the do, so now we're doing it. So every week we're educating these staff using bedside teachings and all of that. we're encouraging people to come to this bedside teaching. We're updating the team on what was taught and all of that. That's what we're doing, bedside teaching. So now study. So we're now studying what interventions we have undertaken. Okay. So the first, week, we realized that 50% of the patients were rolled. Okay. We measure, I mean, if someone rolls, obviously it's gonna be documented in the system, so we definitely know. So based on what we put together, we realized in the first week, let me say 30% of the people of the patients were rolled. Second week, using that same, teaching thing, in which we said we're doing it for 1 month. So we're doing it every week for 1 month. That was a plan. And the do is what we're actively doing. And the first week we did it. So we already have that data, but we can still do, prior to starting that one, we can do maybe an assessment or something. And obviously it's still below because we already know about that. But then with the first week, did a bedside teaching, blah 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 blah, and we did the chatting on maybe a run chat against time. So the number of times patients were rolled for hourly in a day against you know the patients being rolled and all of that. And so we did it the first time, and we realized that 30% of patients were rolled for hourly. The next week, 40% of the patients were rolled. The next week, 40% of the patients were rolled. 45 of the patients were rolled in 1 month. We know that 45% of the patients were rolled. Okay. So now we've studied it based on the outcome, okay, and the process. We're looking at the process as well. That's the studying and the act. So the act is, we can decide to say, should we adopt this, change, or should we abandon this change, or should we adopt and adopt? We make a bit tweak with the way we do the bedside teaching and all of that, or should we adapt and adopt? Make a bit of a change and then adopt it. So that is the thing about the PDSA cycle. Obviously, you can't just sit down and do this your own. It's a team. So you meet, intermittently, and then you discuss this bit. Okay. So, and then you do whatever you have to do based on the plan. So that's what the PDSA cycle is. Okay. So in bit, you've got, so that's the first one. Remember, we had series of them, maybe four or so. So the first one is a bedside teaching, and maybe employing more HCs and healthcare assistants to help the nurses and all of that. We test this out in bit within that period of that 4 months. Okay. And based on the overall testing, we can measure to see if that has increased by 70%. And if that has increased by 70%, brilliant. We can decide to keep these, change. And if it's more than 80%, brilliant. Okay. And so that is the whole, principle of the PDSA cycle, or the Institute for Healthcare Improvement module. Okay. So I said we'll talk a bit more about measuring improvement in QIProject. So first of all, you've got to be observant, see and understand the variation. So we talked about, chatting out. It depends on the study. Sometimes you might not have to chat, but it's always good to kind of chat using chat to be able to see the trend. And so it depends on the team and the way they want to go about it. But one has got to be observant, okay, see and understand the variations and all of that. Observation does not replace measurement. So the fact that you're observing the whole process does not replace the measurement. The outcome has got to be measured. We need evidence. So we can now say, okay, there is a 70% increase, or maybe there is a 50% increase in the percentage of people, of patients in that ward, in that hospital rolled in that month period. Okay, so we can be objectively be we can be able to know whether that change made an improvement or not. Measuring change should be done over time, obviously. It involves people. Like I said, it's not a solo venture. Three types of measure: outcome, processes, and balancing. So we talk about the outcome is a result, and the process is the systematic, the changes that happen along the way. Balancing basically, means that are there other parts of the system, the change effect. If because of rolling, nurses are not able to give medications, you know, we need to think about all of those bits. So you're balancing things, so making sure that that does not affect other important, aspects of the whole, you know, system. Measure baseline, we talked about that. So it could be the audit we did before, or even prior to that, you can decide to do a mini, audit, and just to get a baseline before you start to know if there was an increase or not. Okay, you know where you start from. If possible, when testing out to change, measure improvements, and track them to help to see the trend. Some, QI projects, you can't really do the chatting, but it's always advisable, if possible, to use the run chart to chat and use quantitative or qualitative data. So quantitative data is using the chart, maybe 50%, 60% increase and all of that, using that diagram and all of that. But with the qualitative, you can take pictures or maybe people's or the services or the patients, or relatives, feedback and all of those bit can be some of the data to kind of support, you know, your outcome or measure the outcome. And so, thank you so much for today. I've put some references here. I'll put it on the YouTube site as well, so you can click and read more a bit about that. But thank you so much for watching. Please like, subscribe, and share. I'm looking forward to our next session. Thank you. Bye.